computer crash right at the end, and I had to buy a brand new computer. So this is my new computer. So hopefully, knock on wood, knock on my head, hope everything will go well. So over the next 50 minutes or so, I'm going to talk about pediatric head and neck radiology. And the outline of this talk is we're first going to talk about various infections involving the head and neck. And then we'll talk about congenital anomalies and really spend some time going over the branchial anomalies, because that's obviously something that you'll end up seeing. And then hopefully, if we have enough time, excuse me, we'll end up with the vascular anomalies. And these vascular anomalies are the craniofacial malformations. And what I'll do is I'll introduce the Olympic rings approach to the vascular anomalies. And I think once we get there, you'll see what I mean. So, from a radiologist standpoint, I don't know about an ENT standpoint, but certainly from a radiologist standpoint, one of the big challenges that you have is that head and neck can be challenging. It's especially challenging at night, especially if you have a child that comes in that has a mass in the neck. So the first thing that I want to do is that when you are looking at kids that come in, both of these have masses involving the left side of the neck. So this is more solid, and you can see in this one, there are multiple enlarged lymph nodes, but they have low attenuation in it. And the first thing that we have to get our definition correct is that although you can argue that the pathophysiology is similar, that they're both due to infections, the one on the left is really cervical adenitis. So an adenitis is a painful enlarged lymph node that's solid. Now, if you end up having a painful enlarged lymph node that contains low attenuation, such as this, you can see the low attenuation. The proper terminology is suppurative adenitis. So, oftentimes I'll end up seeing these called abscesses. These are not real abscesses, but it's suppurative adenitis. And it's important to remember these two specific terms when we talk about infection, because we're going to revisit this. And if you're not clear about the definition, you're going to get confused as we move forward. So this is an example of a child, two children that come in with the exact same etiology. And as Dan knows, I actually do see patients on Wednesday afternoon. In fact, I just got back from clinic about an hour ago. And this is similar to a case I saw about 6 or 7 months ago, where the patient came in. It wasn't a child, it was about a 25-year-old that we thought had lymphoma clinically. And I remember when we looked at this, we saw this clumping of lymph nodes right here and maybe a little bit of reticulation of the subcutaneous fat. And anytime, especially in children, when you see this clumping of lymph nodes and they may have a low-grade fever, then you always have to raise the possibility of cat scratch disease. So this is cat scratch disease, and this is cervical adenitis. This is another example of cat scratch disease, and here we can see the inflamed lymph nodes. We see the low attenuation, and this low attenuation, again, is suppurative adenitis. It is not a true abscess. And it is important because if you call this an abscess, then this could potentially be drained. But if you put it together and you say that there's suppurative adenitis and you raise the possibility of cat scratch disease, then you can test for levels of Bartonella henselae. And if the levels are high, then you can go ahead and treat these patients with antibiotic therapy. So this is just a tangible example of why it's important to separate adenitis and suppurative adenitis and not call it an abscess. Now, here's another example. We don't see this in the United States very much, but I know we have people on this call from Asia, and especially when I go to India and South America, if I see something like this and then I see this lymph node on the left, well, I'll tell you what ended up happening in this case. So this is a patient that has a conglomerate nodal mass on the left side of the neck in a child. This was actually a young adult that I saw in tumor board back when I was at UNC. This is back in the last century, but I like to keep these old cases because, life's about storytelling. So I looked at this and I said, this is a metastatic nodal disease. This was actually at our head and neck tumor board. And I thought it was a metastatic level 2 lymph node with extracapsular penetration. Well, all the biopsies were done. All the biopsies were negative. We were scratching our heads. And finally, someone much smarter than me decided to test a PPD. And it turns out both of these are examples of tuberculosis. So this was actually tuberculous adenitis. So again, tuberculous suppurative adenitis. This is tuberculous adenitis, and this is tuberculous suppurative adenitis. So the thing about tuberculosis, in the Midwest, we tend not to see a lot. When it involves the neck, it's been given this scrofula. This is tuberculosis of the neck, and it is the great mimicker. And it's one of these things where I learned as a resident, you only see what you look for and you only diagnose what you know. And in order to make the diagnosis, you have to think of the diagnosis. So if you see something like this, and especially if you're in an endemic area, Detroit, maybe because we do have an international airport that flies in, but especially if you're in New York, if you're in Miami, if you're in San Francisco, if you're in Texas, you are going to be seeing patients with tuberculosis. So in the back of your mind, we always have to think of tuberculosis. Remember to test for PPD in those perplexing cases, and the lymph node biopsy will show the granulomatous inflammation and the caseation necrosis. Now, here's an example of sort of the radiologist's nightmare. So in the middle of the night, maybe it's an ENT nightmare too. You have a child that comes in, you look at the lateral neck film, and what you see here is this diffuse increased soft tissue thickening involving the prevertebral soft tissues. Now, when we look at the neck CT, what we see is diffuse thickening of the soft tissues, but we see this low attenuation right here. Now, back when I was a fellow, okay, this is back in 92 to 94, this was termed retropharyngeal space abscesses. And I remember with my mentor at the time, and he worked with very well-known ENT surgeons. I don't know if you know the name of Nick Cassisi or Scott Stringer and those folks. Both of those were well-known. Cassisi wrote a very one of the definitive textbooks on head and neck with Rod Millian. And then Scott ended up becoming chair at, I think, a University of Mississippi. So what would happen is that they would take these patients and they would take them to the OR and they would drain them. And they got maybe a cc maximum, a cc and a half, and sometimes it was just dishwatery fluid. Well, this is what we used to call retropharyngeal space abscesses. But if you look at the anatomy is that this is the posterior pharyngeal wall. This is the visceral fascia, sometimes called the pharyngomucosal fascia or pharyngobasilar fascia. It has different names. And then right behind it is the retropharyngeal space. And if you look closely, you have these paired lymph nodes right here. So notice there's a medial and a lateral group of these lymph nodes. So what this is, it turns out that this is not a true retropharyngeal space abscess, but it's suppurative adenitis. So fast forward from 1994 to 2024, which will be in a month or so, we've now really determined that this is suppurative adenitis. And if you see this low attenuation that's off midline, and the patients have a stable airway, well, as we now know, these patients can now be treated more conservatively. They don't have to go to the operating room, and they can be treated with broad spectrum antibiotics. So again, suppurative adenitis, not an abscess, and this suppuration is due to this retropharyngeal lymph node, which is off the midline. Now, here's an example of diffuse low attenuation involving the retropharyngeal space. And if you look real closely, we can see this line right here. So when we look behind the pharynx, we always call this the retropharyngeal space, but in actuality, there's a little fascial layer right here, and that's the alar fascia. And the yellow lines right here actually point to the alar fascia. So in this particular case, we were able to see it. So the true retropharyngeal space is from the I'll just call it the visceral fascia to the alar fascia. This is the true retropharyngeal space. And then the space from the alar fascia to the prevertebral fascia is what we refer to as the danger space. So in this case, if you do see this effusion, slow attenuation of this edema, and you can see the fascia, that kind of supports that you're dealing with retropharyngeal space edema. So in general, the retropharyngeal space edema tends to be low attenuation. It can have a little mass effect, but again, juxtapose this to the cases of retropharyngeal space abscesses that I'll show in a couple of slides. And this, in fact, is a case of a large retropharyngeal space abscess. So notice how this is predominantly midline, occasionally can be a little off the midline, but still within the expected location of the retropharyngeal space. And we can see it's actually extending, in this case, laterally to involve the lateral aspect of the neck. So this is a true retropharyngeal space abscess. Now, one thing about retropharyngeal space abscesses, or in general, abscesses that occur in the head and neck area, is that if you look at an abscess in the brain or an abscess in the liver or anywhere else in the body, They're low attenuation centers with a thick enhancing rim. In general, the abscesses in the head neck area do not have this thick enhancing rim. So if you see this large fluid collection, you don't see the enhancing rim, that does not exclude an abscess. So the main thing is to really look for that fluid collection in the retropharyngeal space being midline, and that tells you that you're dealing with a true abscess involving the retropharyngeal space. Here's another example of a retropharyngeal space abscess. We can see expansion here in the retropharyngeal space. We can see these multiple air pockets. And then when we look at this coronal images, we can see why this patient developed this. This was a child that went to a fair and unfortunately bit off one of those plastic fork, little fork things, those little things that make the fork. I'm blanking on the name of it, but it ended up piercing the posterior pharyngeal wall, and this allowed egress of the fluid involving the pharynx to extend back into the retropharyngeal space. And in fact, this was the cause of that retropharyngeal space abscess. So these are two examples of abscesses, but they're in different locations, and both of these, again, are in kids. Now, notice this abscess here on the right-hand side, and notice this abscess here in this space. This abscess is actually located in the tonsil, so this is actually in the visceral space, and I'll talk a little bit more about this abscess in the next slide. But this is a tonsillar abscess, and in this case, notice how the tonsil may be a little bit large, but this abscess is actually mapped to this space right here, which is next to the pharynx. So what do we call the space next to the pharynx? That's the parapharyngeal space. The reason why it's important to separate out the tonsillar abscess from the parapharyngeal space abscess is that if we tell you, the surgeons, that yes, this is a tonsillar abscess, you can biopsy, or should say you can drain this through an intraoral approach. But on the other hand, if we say that this is in the parapharyngeal space, notice how it's obliterating the parapharyngeal space. And look here, see how the normal parapharyngeal space is here? Notice how it's not there, and here's there on the left, it's symmetric. If we say that this is in the parapharyngeal space, then you would have to do a cervical approach. In fact, like I said, life's about storytelling. I remember this case. This is back when I was at UNC, again, in the last century. One of our superb residents, actually a terrific resident, it was read out initially as a tonsillar abscess. The surgeons ended up doing multiple passes and couldn't get anything. Then they came and showed us the next day, and yes, indeed, this was in the parapharyngeal space. This patient was taken to the OR for a cervical approach. So even though it's just maybe 5 millimeters or so from here to here, it does make a difference on the approach because these tonsillar/peritonsillar abscesses are drained through an intraoral approach, where these are drained through that cervical approach. So I'll spend just a couple of minutes on this, and when we get done, Dan, you can tell me how you guys are taught. I'm going to talk about these abscesses right here that are located within the tonsillar fossa. I have heard both peritonsillar abscess and tonsillar abscesses used to describe this. So anytime that you have an abscess involving the tonsillar fossa, these are the ones that are drained intraorally. Some people claim that, well, you can't have a real tonsillar abscess because if you did, then all of this lymphoid tissue that comprises the palatine tonsils would be basically immediately melted, if you will, due to the inflammation. And therefore, anytime you see an abscess, it has to be below the capsule. And this is what gives you this peritonsillar abscess. So I don't know what the actual terminology, what's being taught. Maybe it varies in the ENT literature too. But this is just an example of a tonsillar/peritonsillar abscess pre-treatment, pre-drainage, I could say. And then after drainage, we can see the air-fill cavity. Maybe with the leap of faith, that's a capsule. I don't know. But again, the main thing is to be able to separate out an abscess that's involving the tonsil from an abscess that's involving the parapharyngeal space. And the last thing that we'll talk about when we talk about infections involving the head and neck is that we'll specifically talk about this one syndrome that's associated with tonsillar abscesses. So if you do have a tonsillar abscess, and this is something that shows up always for the radiologist on our boards, if you will, and I'm not sure how, as the ENT surgeons, you're sort of exposed to this, but anytime you have a patient that comes in with a tonsillar abscess, some of the things that you want to specifically look for is to make sure there's patency involving the great vessels of the neck. So I always like to count to four. Number one is the internal jugular vein. Number two is the internal carotid artery. Number three is the contralateral internal carotid artery. And number four is that we don't see the internal jugular vein. So this is actually internal jugular vein thrombosis that's due to inflammatory. So this is actually a thrombophlebitis from this Lemire syndrome, or I should say from this infection. And when you have a tonsillar abscess associated with a thrombophlebitis involving the internal jugular vein, this is sometimes associated with septic emboli in the lungs. And this is what's referred to as Lemire syndrome. And this was named in 1936 by Andre Lemire. Now, this was actually initially described not for the head and neck, but it was actually initially described in postpartum patients back in the early centuries. But now from a head and neck standpoint, it can be seen in any infections involving the pharynx or the oral cavity or the mastoid air cells, but specifically it's associated with thrombosis of that vein. The good thing is that there's a good prognosis due to antibiotics and anticoagulants. So what we did is that we talked about some of the common infections that you as ENT surgeons may run into in the middle of the night. So I know you guys probably take a lot of call, and those are in a way, triage, those infections that you certainly want to be aware of and you don't want to miss. The next thing that we'll do is that we'll talk about congenital anomalies involving the pediatric head and neck. So the first thing that I want to do is talk about are the branchial anomalies. Now, in order to talk about branchial anomalies, and we'll talk about first branchial cleft anomaly, second, third, and fourth. We'll go over that in annoying detail, if you will. But the first thing about the branchial arches, and honestly, I'm not the smartest person. It took me 20 years to figure this out. But back when I was in medical school, we looked at Moore's embryology and Langham's embryology. Now in medical school, my son's in medical school right now. They just look at PowerPoints right now. Everything's on PowerPoint. But back in the day, we actually looked at something called textbook. And in those textbooks, we always used to see this diagram. And so it took me about 20 years to figure out where this diagram actually came from. And what it is, it's actually the developing embryo right here. And what you do is that you take a coronal image. Basically, you cut this embryo coronally. And when you look at the branchial apparatuses, what you'll see is that this is actually internally, this is actually within the embryo, and this is outside of the embryo. So this is external, and this is internal. And for me, it was a bit of a revelation because I never could figure this out, but it helped me understand the first branchial anomaly that we'll talk about, and those are anomalies involving the first branchial apparatus. Now, one thing about branchial anomalies, and I know we have radiologists on this presentation, which is great, is that the diagnosis of a branchial cleft cyst or a branchial anomaly, again, we'll talk about those, is based on the histologic presence of stratified squamous or ciliated columnar epithelium with a fibrotic wall and lymphoid follicles, okay? This is a histologic diagnosis. So the pathologist will look at this and they'll see these histologic characteristics and they'll call it a branchial cleft cyst or a branchial anomaly. They do not know where it's coming from. So they can look at this and they don't know whether it's coming from the first, the second, the third, or the fourth. So the job of us as the radiologist and also the surgeon is to actually map out where that branchial anomaly is. So you're going to have to figure out and say specifically, is this involving the ear region? Is this involving the neck region? Is this involving the thyroid area? Is this involving the superior mediastinum? And you'll see while I'm saying this in a couple of slides. But just realize that this branchial anomaly is a histologic diagnosis, but actually where it's coming from really depends on us. So the first one that I will talk about is the first branchial arch, the first branchial anomalies. So when we look at development of the branchial apparatus, like I mentioned before, this is external and this is internal. Each branchial arch has a cartilage, it has a nerve, and it has a vessel. And when we look at outside, when we look at this developing membrane, the developing embryo, this is the first branchial arch, and this is the first branchial groove. As this first branchial groove starts to invaginate, this ends up forming the external auditory canal, which is seen here. So here's the external auditory canal. The first branchial pouch is actually located internally. So the first branchial pouch forms the middle ear cavity. So when we look at the embryo, this is the middle ear cavity. These are the formation of the developing ossicles. There's the middle ear cavity, there's the middle ear cavity, and there's the middle ear cavity. So therefore, when we talk about anomalies involving the first branchial arch, these are sometimes referred to as duplication anomalies of the external auditory canal. Now, I got to show this paper right here, and I'll show it for a couple of reasons. So, I'm a head and neck radiologist. I'm a neuroradiologist. Back when I was a fellow, back when I was a resident, I wanted to do my fellowship at University of Florida with Tony Mancuso. So I remember calling up Tony. I was super enthusiastic about academics, and I still do. I still love to write and so on and so forth. But fortunately, this was before the texts and phone calls and anything else. So you can imagine if I had a text or a phone call, it was terrible. I was calling him all the time. And finally, he said, "Let me get this clown off my back." So he said, I've got a project for you. He said, "I've got this series of first branchial anomalies that we had gathered over time at University of Florida." So he gave this to me. So I diligently went through each one of these. And so one of the first papers I ever wrote, and this is my first presentation ever, was at the Radiological Society of North America in 1993. And it was the evaluation of first branchial anomalies. So first branchial anomalies have a special place in my heart. So when you look at the first branchial anomalies, these were actually described by the work classification. And ironically, this is where I spent 12 to 13 years of my life in Ann Arbor. So I was actually in the work conference room at U of M. So it's funny how life makes full circles. But the first branchial anomalies are divided into a type 1 and a type 2. The type 1 first branchial anomalies are felt to be, quote unquote, again, duplication cysts, but they present as cystic masses involving the parotid gland in a child. So if you are looking at a child and you see this cystic mass right here in a child, and they're otherwise asymptomatic, they're not febrile, they're pure cyst, etc., then this is the typical appearance of a type 1 first branchial anomaly. Now, I'll add one little caveat to this. If this was an adult and you end up seeing a pure cyst involving the parotid gland, we could call that a parotid cyst. We could call this a sialocele. But one thing that we ended up finding out is that we looked at about 100 of these first branchial anomalies. And it turns out, not 100 first branchial anomalies, but 100 branchial anomalies. And it turns out some of these things that we thought were actually sialoceles in an adult, actually, a certain percentage of those turned out to be undiagnosed type 1 first branchial anomalies. So it's something that I always include in my differential. So even in adults, they can present, but oftentimes they're asymptomatic and they didn't present as a child. They just were found as an adult. Now, the type 2 first branchial anomalies are rare, but when I talk to my colleagues in ENT, they're a little bit more common than you think they are. So these type 2 first branchial anomalies, again, are classified as duplication anomalies of the external auditory canal. But what they are, they're actually more of a fistula formation. So they arise at the junction of the cartilaginous and bony external auditory canal. And what my colleagues will tell me in Peds ENT is that sometimes you'll just see a little papilla. So if you see a little papilla in a child, then oftentimes that's indicative of a type 2 second branchial anomaly. But if you do see a little fistula formation, then this fistula can extend all the way inferiorly along a tract, and eventually this tract extends superiorly to the skin in the submandibular space. So if you look real closely, there's a little high attenuation area right here, and that is actually a little bit of this fluid or this fistulogram that we did that's extending to the skin surface. And on this CT scan, you can see this tract extending all the way. And when you look at the skin, there's a little dimple right here. So if you do have a child that presents with a little dimple, on the other hand, you see a papilla, or you have unexplained infections of the parotid gland, you have to consider the possibility of a type 2 first branchial anomaly. Now, the other piece of information why I wanted to specifically show this is that, look, those of you, you guys are all residents there, in your program. I'm sure your attendings are always asking to work on projects. And I know everyone's really busy, everyone's overworked, and so on and so forth. But the one thing that I will say is every time that I've worked on one of these projects, I still remember the first case report I ever did. It was actually on rhabdomyolysis of the kidney. I still remember that 40 years later. So the point is, if you make the effort to do these case reports or case series or more, larger projects, that piece of information always stays with you. And I guarantee you, one day you're going to end up using that information, in your practice. So, be open-minded when you're approached by that. Well, the second branchial arch is can also give us various anomalies. So the second branchial arch, the most typical thing that you'll end up seeing in your practice is this. This is the classic cyst lesion involving the anterior aspect that abuts the anterior portion of the sternocleidomastoid muscle. So a couple of points about this. Number one, and my son's in med school, and so he came home one day and he said, "Dad, my ENT colleague wants to write up a case report." And I said, "What?" He said, "Well, it was actually a branchial cleft cyst in an adult that ended up actually being a metastatic squamous cell carcinoma metastases." And I said, "You can go ahead and write it up, but it's well known for a long time." So the point being is that you have to be incredibly wary. In fact, it's almost impossible to find a true second branchial cleft cyst that presents in adult. Anytime that you see a cystic lesion in an adult, especially if there's a thick enhancing rim that is located in the region of level 2, in adult, by definition, you have to exclude squamous cell carcinoma metastases from HPV. So don't fall in the trap of talking about an adult presenting with a type 2 second branchial anomaly. Okay, avoid that. In an adult, you have to think of HPV positive metastatic squamous cell carcinoma. The second thing is that this is what you'll most commonly see. But since we are talking about Peds head and neck, there are actually 4 types of second branchial anomalies. So what we talk about is the type 2 second. There's actually a type 1, a type 3, and a type 4. And this was named after the famous paper by Bailey. So this is, if you've done Peds head and neck, you've probably heard about the Bailey classification for second branchial arch anomalies. So what I want to do is go through these, and these are actually all path-proven cases of second branchial anomalies, but these are the different types. So this was a case of a type 1 second branchial anomaly. So when I remember when I looked at this, and I looked at the initial report, this was felt to be an infectious sebaceous cyst. So this was resected because it was just going to be a sebaceous cyst, and lo and behold, the pathology came back branchial anomaly. Now, you don't know where it's arising from, but again, the pathologist tells you it's a branchial anomaly. When we as a radiologist or you as a surgeon say, "Hey, I removed this from the skin, and it was actually continuous with the platysma muscle," then if you understand the embryology, you know that type 1 seconds are actually located below the skin surface, and that's why you can make that sophisticated diagnosis of a type 1 second. Now, this is the classical example here. We already went over that in great detail. This is a type 2 second branchial anomaly. Now, back when I was a resident and I was doing my Peds rotation, I always heard about these fistulas that extended from the tonsil that sometimes can course through the internal and external carotid arteries. So a type 3 second branchial anomaly, by definition, is a second branchial anomaly that extends between the internal and the external carotid artery. And occasionally it can fistulize with the viscera. So this little gray right here is representing the pharynx. So if you actually have a patient that comes through and has recurrent infections involving the tonsils, and you see a little fistula and you inject it and it extends through the internal and external carotid arteries and then extends down inferiorly, well, this is a type 3 second branchial anomaly. So for those of you that have heard, quote unquote, talked about the fistulas for a second, this is that specific kind. And then finally, this is one where I've just gone down the tubes once. I remember I was totally embarrassed, but hey, that's what life, you got to learn from your mistakes, right? So on occasion, what ends up happening is that we see these purely cystic lesions that are actually located between deep to the carotid artery and lateral to the pharynx. So if you see a cystic lesion here, then one of the things that you have to include in your differential diagnosis for pure cyst is actually a type 4 second branchial anomaly. When I look at this, my differential is going to be, could this be a tonsillar cyst? Well, the thing is, it's just lateral to the tonsil because there's our tonsil. It is overlying the deep lobe of the parotid gland, so you always have to consider maybe a parotid cyst or potentially a pleomorphic adenoma. Also, too, because it's in the retropharyngeal region, is it possible this could be a metastases from a thyroid cancer, et cetera? But when you have a pure cyst right here, one of the things that you have to think in the back of your mind is that, is this a type 4 second branchial anomaly? And remember, it's located between the carotid arteries and lateral to the pharynx. So when you see this included in your differential diagnosis, I think especially that this will still have to come out. But on the other hand, you can make a difference by just suggesting that possibility. Well, the third branchial anomaly is a branchial anomaly that is the third. And what it does is it looks like this. So the third and the fourth are kind of closed over by the cervical sinus of His. So we talked about the first, we talked about the second, here's a third, and here's the fourth. So what happens embryologically is that the cervical sinus of His ends up being encapsulated or enclosed. And what ends up happening is that if you still have this residual sinus right here, this can lead to either a third or a fourth branchial anomaly. So I'm going to go over this, and I'm going to tell you it can be confusing because I've been doing this for, again, like 25 or 30 years. And when I go to different meetings, I hear different people showing what they consider a third or a fourth. What I'm going to do is I'm going to give you my approach on this, and it's really based on the embryology. And all the cases that I'm showing are actually proven branchial anomalies. But again, it's really up to us to map it. So when we look at this, we have to take into consideration the embryology. So the third branchial anomaly is actually more common than you think it is. In fact, it's the second most common cystic lesion in the posterior triangle. The most common is a lymphatic malformation. So embryologically, the third branchial arch and its anomalies arise posterior to the carotid artery. So these fistulas pierce the thyroid membrane. They communicate with the piriform sinus. Now, again, it's been very, very variable, but there was an article that was written by a good friend of mine who is actually chair of radiology at Sick Kids up in Toronto. And both the third and the fourth branchial anomalies communicate with the piriform sinus. Now, he felt that maybe if it's a little bit more rostral, it's more likely to be a third, but again, that's a little bit variable. But the key thing is that these pierce the thyroid membrane. They then course superiorly between cranial nerve 9 and cranial nerve 10, and then they run superior to the superior laryngeal nerve, and then they course inferiorly along the posterior triangle. So these are actually pathologic proven third branchial anomalies. So I remember this case right here. This was an older kid. This was an adolescent. We saw this. Again, I was worried about things like tuberculosis, metastases, et cetera. But this was pathologically proven third branchial anomaly. Another example here, we're in quote unquote the posterior triangle. I thought that this was going to be a lymphatic malformation, but lo and behold, it turned out to be a pathologically proven case of a third branchial anomaly. So you could call this a third branchial cleft cyst. So notice how this is in the posterior triangle. So that's our takeaway message. When you see something here in the posterior triangle, think about also include a third branchial cleft cyst. Now, as I mentioned before, once this cervical sinus of his closes up, well, you could have something coming from the third, or you could have something coming from the fourth. So how do we determine this embryology? Well, remember the fourth branchial arch is associated with the recurrent laryngeal nerve. And so the course of the fourth branchial arch has a course similar to this. So embryologically, the fourth branchial arch has a course that crosses under the right subclavian artery on the right and the aortic arch on the left. So therefore, embryologically, the fourth branchial arch and the fourth branchial anomaly should extend inferiorly into the mediastinum. So unlike the third, which extends on the dorsal surface of the carotid artery, this ascends along the ventral surface of the carotid artery. This also pierces the thyrohyoid membrane, but the main thing is the descent into the superior mediastinum. So I know when you're on your pediatric rotation, you will see patients presenting like this. So when you have a child that presents with unexplained recurrent anterior neck infections, right, you always have to consider the possibility of a congenital etiology. And one of the most common congenital etiologies is going to be due to an underlying branchial anomaly. So this is an example of a child that had these anterior recurrent neck infections. And if you look at the thyroid gland with the leap of faith, you can see this little track right here. When we look at the left-hand side, we can actually see this in a little air right here that's communicating with the piriform sinus. So when we look at the coronal images, here's this air tract that inferiorly butts the superior portion of the thyroid gland, and superiorly it communicates with the apex of the piriform sinus. Embryologically, this is a fourth branchial anomaly. Now, sometimes I've heard it called third, sometimes I've just called it branchial anomaly, but if you understand that this communicates with the piriform sinus and eventually extends inferiorly, the thyroid gland is along its course, and you can make the diagnosis of a fourth branchial anomaly. So that's how I separate out the third and the fourth. So to summarize the branchial anomalies, we have something involving the parotid gland, which is a type 1 and a type 2. Remember the second, this is typically associated with the tonsil. So type 1 is parotid, type 2 is tonsil. And remember the four types, with the most common being the type 2 second. The type 3 are the ones, how do we remember this? Well, we remember the posterior triangle. So if you end up seeing a cystic lesion involving the posterior neck, yes, the most likely diagnosis is going to be lymphatic malformation, but you also have to think of type 3 third branchial anomalies. And then finally, the fourth. And how do we remember this? Well, these are the ones that extend inferiorly into the mediastinum, and along the course, it's going to bump into the piriform sinus, and it can occasionally involve the thyroid gland. So in patients that end up having recurrent anterior neck infections or separate infections involving the thyroid gland, that's how we think of the fourth branchial anomaly. So the next thing that we'll talk about is the lingual thyroid, and this is something that you'll see very commonly. So when we talk about the thyroid gland, remember the thyroid gland starts right here at the base of the tongue in the region of foramen cecum. And then what happens is that the thyroid gland has this relative descent in the neck. Now, whether or not the thyroid gland actually descends or whether the neck expands around it, I think for a while is debatable. I think most recently it felt to actually descend. But what ends up happening is that there's our thyroid, the analog of the thyroid gland here. It extends inferiorly, and then it has this complex relationship right here with the hyoid bone. You see the hyoid bone right here? See this little complex relationship? Well, what ends up happening is that eventually it continues to descend until it finally becomes a thyroid gland into the anterior neck. So if you have thyroid tissue that becomes, if you will, I don't want to say ectopic, but fails to descend, this is what gives us the lingual thyroid gland. And I know I've seen a couple of these actually at our ENT clinic. So this does not look like squamous cell carcinoma. The few that I've seen in the clinic tend to be polypoid masses that tend to have a reddish hue and almost look like they're hypervascular at endoscopy. And the reasons that's the case is that we know that the thyroid gland typically enhances with contrast. So this is an example of a lingual thyroid gland that's located right at the foramen cecum. This actually has a little bit of calcification in it. And then when we can continue our CT scan to the anterior neck, notice how there's no thyroid gland in the expected location. So this is an example of that lingual thyroid gland that's purely located within the foramen cecum. This is an example of an MR of a lingual thyroid gland. Now, I got to tell you, if I just saw this, I don't know if I would call anything abnormal. I certainly wouldn't call it a lingual thyroid gland. Even when I look at this, it looks a little bit heterogeneous. Sometimes I could mistake that for lingual tonsor tissue. But when you do give contrast, it is enhancing with contrast. So again, to me, this is a non-specific finding radiologically. I would just say that there's enhancing mass in the middle of the tongue base. Maybe because it's located in the foramen cecum, I would raise that possibility, especially in a child. But certainly if I saw this in an adult, the most common things that would come to mind would be squamous cell carcinoma involving the region of the foramen cecum. Now, a couple of things here about the thyroglossal duct cyst is that it can have variable appearance. So point number one, in a child that presents with an anterior neck mass, especially, in a pediatric hospital for sure, but especially if you live in India or in South America or in other places where you don't have as much CT, ultrasound is the way to go. So I'm clearly not suggesting that you perform CT scans on suspected cases of thyroglossal duct cyst. But what I did want to do is go over these imaging findings because they can be a little confusing. So this is an example right here of a thyroglossal duct cyst that's located in the region of foramen cecum. So this was an example of lingual thyroid. So if I see thyroid tissue and it's solid, that's the definition of a lingual thyroid. But on the other hand, if I look at this and I see a cyst right here that's located in the region of foramen cecum and it's cystic, then this is a thyroglossal duct cyst. Now, here's an example of a mass that's involved in the anterior neck, but it's also paramidline. And if you look real closely, there are multiple cysts and there's actually focal areas of enhancement. And if you even look more closely, here's the normal strap muscle on the right-hand side, but look at the strap muscle on the left-hand side. Well, if you just saw this, I've seen this given different differentials. I've seen this called maybe epidermoid, maybe a dermoid, maybe a neoplasm. It's possible if you're in an endemic area, someone could call this cysticercosis or tuberculosis or so on and so forth. But on the other hand, what this represents is another thyroglossal duct cyst. So the point that I want to make is that thyroglossal duct cysts can be unicystic with the single cyst, or they can have multiple cysts. And notice when you have the multiple cysts, we can see these little areas of enhancement. The other thing too is notice how this thyroglossal duct cyst, if I look at the one below, it's more midline. But notice how this thyroglossal duct cyst is paramidline, it's off midline. So then you have to ask yourself, well, how do I tell the difference? Because these are completely different presentations of the same etiology. And the key thing here is that notice how it's embedded in the strap muscle. That's the main thing. It's embedded in the strap muscle. So here's a normal strap muscle on the right. Here it's embedded on the left. Another example here, a thyroglossal duct cyst here. It's anterior midline. It's unilocular. But notice how it's embedded in the strap muscle. So the surgeons, you guys all know that the way you make the diagnosis of a thyroglossal duct cyst is you have someone swallow. Patient will present with an anterior neck mass, and you have them swallow. And if you swallow, the mass moves up and down. So it moves on, if you will, deglutination. That's the sophisticated term for swallowing. So why does it do that? The reason is that the radiological correlate is the following. When I think of the larynx, I think of the larynx as a separate structure. And what happens when you swallow, the food has to somehow get redirected to the pharynx. So how does it do that? Well, the epiglottis has to flop down to close the laryngeal airway, and the larynx has to be pulled up. How is the larynx pulled up? Well, it's pulled up by these pulleys. These strap muscles are like pulleys. So if you've ever been on an elevator, to me, the larynx is an elevator. So when you swallow, that elevator has to go higher. It has to go to a higher floor. How does it get there? Well, it gets pulled up. So that's why when you end up swallowing, you have contraction of these strap muscles. This ends up pulling the larynx. But when the strap muscle contracts, because these thyroglossal duct cysts are in the strap muscles, that's why these thyroglossal duct cysts actually move up when you're swallowed. So clinically, that's a movement on deglutination. And radiologically, this is the most hardest finding that I look for when I'm thinking about a thyroglossal duct cyst. And as a result, because of this course from the tongue base all the way down to the anterior neck, the type of surgery that's performed is that this is the cyst shrunk procedure. So anytime that you have a thyroglossal duct cyst, I shouldn't say anytime because Dan, you guys can tell me if it's still standard of care, but my impression was anytime that you have a thyroglossal duct cyst, because the thyroid tissue starts in the tongue base, you have to take a cuff of tongue base tissue. Then you have to make sure there's not a tract going down to the anterior neck. So this actually is a tract associated with the thyroid remnant. Now, on rare occasions, what you can have is that when you look at this thyroglossal duct cyst, occasionally you can have an enhancing mass within this, and you can have a concomitant papillary thyroid carcinoma. So papillary thyroid carcinomas are the most common type of thyroid cancers that are associated with a thyroglossal duct cyst. I believe that they comprised about 80% of these cancers associated with thyroglossal duct cyst. Occasionally, you can have follicular cancers, and occasionally you can have squamous cell carcinomas on rare occasions. But in general, papillary thyroid carcinoma is most common. As I mentioned before, they're pretty rare. I mean, less than 5% of thyroglossal duct cysts are going to have this. But on the other hand, it's important for the surgeons to know before going in whether there is an underlying thyroid carcinoma. So radiologically, what we end up looking for is that if we do see a thyroglossal duct cyst, see the cystic mass right here, and you do see a solid enhancing component within the cyst, then we have to raise the possibility of an underlying thyroid carcinoma. So remember, from a radiological standpoint, if you do see an enhancing component, then you should raise the possibility of an underlying papillary thyroid carcinoma in a thyroglossal duct cyst. Well, Dan, I'm already at 50 minutes right now. I do have more on vascular anomalies. Maybe we could come back in a future time and talk about that. I want to be respectful of anyone's time. And I also, there's only so long you can listen to me. My kids can listen to me for like 5 minutes and then they run away. My wife never listens to me, but for you guys to be listening to me for 50 minutes, I thank you, but I also feel for you. So is that okay if we just stop here? Maybe we can come back and talk about craniofacial vascular malformations.
Yeah, that's fine. I think that's fair, and we appreciate the time. And I know you had asked a couple of questions earlier. I don't know if any of the residents wanted to chime in, but about like the peritonsillar versus tonsillar.
Yeah, I'd love that. Yeah, please do.
From my experience, and anybody else can come in and chime in too, but with like intratonsillar abscesses, a lot of us just will keep people on antibiotics. Realistically,